Hello there. Today we'll be talking about jaundice. So, jaundice is a yellowish discoloration of the skin and mucous membranes due to an excess of bilirubin in the blood and its deposition in body tissues. Hyperbilirubinemia, hyperbilirubinemia is due to either increased production or impaired excretion of bilirubin. It's a sign of liver disease or a hemolytic disorder when excess blood cells are destroyed in the body due to a pathology or disorder of bilirubin metabolism. Now, normal serum levels of bilirubin are less than 1 milligram per deciliter, uh, and bilirubin may be conjugated or unconjugated. Um, the levels of conjugated and unconjugated are shown on the screen. Although the term jaundice is often used interchangeably with hyperbilirubinemia. The scleral icterus, that is the yellowing of the eyes, is seen when levels reach more than 3 milligrams per deciliter. Below this level, uh, abnormally high serum bilirubin below 3 milligram per deciliter results in subclinical jaundice, subclinical hyperbilirubinemia. And you should note that the sclera have a particular affinity for bilirubin due to their high elastin content. The protein elastin has a high avidity for bilirubin. Okay, and the oxidation of bilirubin leads to formation of biliverdin, which is a greenish colored pigment, as opposed to bilirubin, which is yellowish in color. Now, we should note that when we say uh, bilirubin is direct, we mean that it is conjugated, right? Because there's a classification system for hyperbilirubinemia, which may be either conjugated or unconjugated hyperbilirubinemia. Conjugated hyperbilirubinemia is when the amount of direct, that is conjugated bilirubin in the blood is greater than 15%. If it is less than 15%, then we say the patient has unconjugated hyperbilirubinemia. These are some of the sites you want to examine for jaundice. It's not just the sclera of the eyes. Now, we cannot talk about bilirubin, though this is a physiology lecture, we cannot talk about the bilirubin metabolism and jaundice without delving into the biochemistry of it. Now, bilirubin is an important metabolite of heme and is a toxic substance if it gets to places in the body where it's not supposed to. Okay, so but the body has developed systems for safely eliminating it. All right, now bilirubin and its metabolites provide the normal, the yellow color to bile and stool, and to a lesser degree to urine. Now, most of bilirubin is formed from the breakdown of hemoglobin in senescent red cells, as we saw during our lecture on erythropoiesis. Now, this schematic summarizes what we'll talk about in the next few slides. Uh, bilirubin metabolism. Now, the red blood cells that break down to and the hemoglobin part of the red blood cells, the heme breaks down to form unconjugated bilirubin. Now, this bilirubin binds to albumin and within the uh, travels within the circulation, all right, until it gets to the liver. So this is a liver hepatocyte within the liver. So within at that point, the bilirubin dissociates from the albumin and is taken in by hepatocytes. Now, hepatocytes will conjugate it, which will make it water soluble by adding glucuronic acid moieties to it. Right, this uh, this makes it into conjugated bilirubin, which is water soluble. All right. So the conjugated bilirubin is now secreted into bile. All right, and bile is we know bile is important for digestion, especially of fatty meals, right? So bile is secreted from the gallbladder into the small intestine. All right, and so from there the bilirubin thus secreted in bile will eventually be broken down by bacteria in the gut, especially in the large in the colon. All right, so it's broken down into urobilinogens and similar metabolites, and most of it is excreted uh, as stacobilin and stacobilinogen in stool. All right, but some of the urobilinogen escapes from the gut through the enterohepatic circulation. It passes through the portal vein back to the liver, via the portal vein. So the enterohepatic circulation means that some of the urobilinogen that gets back to the liver will again go through this route through the biliary system and again reaches the intestines. But again, some of the urobilinogen does not go back through the biliary system. Some of it will escape from the hepatocytes into the blood, into the circulation, and this urobilinogen will get to the kidney eventually, right? And this will give some of the yellowish color of urine. This will give urine some of this yellowish color, and this eventually excreted as urobilin inside urine. So this is summary of bilirubin metabolism. Okay, this cartoon shows a similar summary. All right. So we said 80% of it will of bilirubin is gotten from senescent blood cells and prematurely destroyed erythroid cells in the bone marrow. The remainder originates from turnover of various heme containing proteins. So we must know that it's not only hemoglobin that contains heme. There's also myoglobin, for instance, inside the muscles and some other substances. All right. So about 4 milligram per kilogram body weight of bilirubin is produced daily. We should make a note of this value. Bilirubin is generated by a two-stage sequence, right? It's a two-stage sequential degradation, okay, that primarily takes place in the cells of the reticuloendothelial systems, um, especially the spleen. Okay, so these cells, especially macrophages within the reticuloendothelial system, they take up the heme, and the enzyme heme oxygenase acts on the heme to produce carbon dioxide and biliverdin. Biliverdin is a greenish pigment. Okay, so when the heme is first broken down, it's carbon monoxide and biliverdin that is produced. Okay, um, yeah. So okay, you can. This cartoon shows what happens to heme inside the macrophage in the reticular endothelial system, such as inside the spleen. Okay, so the heme, uh, the the ion the ion is either stored as a ferritin or released as transferrin to be transported to the liver and other body parts. All right. So, but the porphyrin portion of heme will be broken down to form the initially biliverdin, but eventually the biliverdin is converted to bilirubin. Okay. Now the carbon monoxide is excreted by the lungs. Biliverdin is acted upon further, all right, by by the enzyme biliverdin reductase. Now this then produces bilirubin, which is an orange yellow pigment. So we know that biliverdin, the initial substance, is greenish, but the final substance bilirubin is orange yellow. All right. Now, the bilirubin at this point is not soluble; it's insoluble in water, right? It's not water soluble. Okay, so it is transported in circulation bound to albumin. Albumin binds very avidly to bilirubin, and under ideal conditions, no unbound, unconjugated bilirubin is seen in the plasma. Okay, so albumin binding limits the escape of bilirubin from the vascular space. All right, because bilirubin is toxic. It's toxic to the brain. For instance, can cause um, some serious neurological disorders if it gets to the brain in enough quantities. All right. So the binding to albumin ensures that the bilirubin stays within the circulation and does not enter into the tissues. Does not enter into the kidney, into the brain, and so on. Now, the albumin bound bilirubin eventually gets to the liver, right, where the bilirubin dissociates from the albumin and is taken up by hepatocytes, um, either by passive diffusion or an active transport, receptor mediated endocytosis. Okay. All right. So if we take a look at this cartoon, it shows the arrangement of the branches of the portal vein, their relationship, their relation to the hepatocyte and to a bile duct. Now we can see, okay, these are branches of this is a branch of the portal vein, and you can see the vein running through the liver to a central vein. This central vein will eventually feed into the hepatic vein that will carry blood from the liver to the inferior vena cava. Okay, so we can, so this, each of this is a one hepatocyte, this is another one, this is another one, right? All right, so the hepatocytes, the liver cells, they have their two opposing surfaces that that are adjacent to the vein, to the branches of the portal vein, and to the bile duct, to a bile duct. All right, so the part of the hepatocytes adjacent to the now this is called a sinusoid, right? The sinusoid, is the branch of the portal vein, right? So the part of the hepatocyte adjacent to the sinusoid is called the sinusoidal membrane of the hepatocyte, whereas the other side that's adjacent is to the bile duct is called the canalicular membrane of the hepatocyte. All right, so the albumin bound bilirubin gets to the sinusoids, and at this point it dissociates from the albumin, and the bilirubin is taken up into the hepatocytes here. So the hepatocytes will um, conjugate it, conjugate the bilirubin, and thus make it water soluble. Then the newly conjugated bilirubin will now pass across the canalicular surface of the hepatocytes into the bile duct, right? And from the bile duct drains into the gallbladder where bile is stored. Okay, so this shows something similar. We can skip this. All right, so conjugation makes bilirubin water soluble, right? And this facilitates its secretion across the canalicular membrane and excretion into the bile. All right, so the conjugation uh, uh, is with glucuronic acid, and this is done by enzymes called uridine diphosphoglucuronic trans glucuro diphosphoglucuronic glucuronosyl transferase UDPGT. The enzyme esterifies two glucuronide moieties, right, to the bilirubin, to each bilirubin. Okay, now, so the conjugated bile will be excreted in the conjugated bilirubin, I beg your pardon, and other substances that are to be excreted in bile, uh, will now be transported across the canalicular membrane of the hepatocytes into the bile. All right, but we should note that some of the conjugated bilirubin will actually escape back into the portal circulation, back into the sinusoids. Let's go back and see what we're talking about. So we say that the unconjugated bilirubin dissociates from the albumin within the sinusoids and passes across the sinusoidal membrane into the hepatocyte. And inside the hepatocyte, it is conjugated. Now, most of the conjugated bilirubin will now move uh, into this bile ductules, right? But some of it will actually move back in the opposite direction and end up in the sinusoid, and from there, the sinusoids drain into the central vein, and from there, it moves to uh, the blood from central vein eventually gets to the inferior vena cava and passes through systemic circulation. Okay, so all right, and yes, and the bile drains into the small intestine. Okay, so the conjugated bilirubin and even some unconjugated bilirubin may escape the hepatocyte cytosol back into the plasma, right? Meaning they did not get into the bile ducts. They may get back into the sinusoids, and eventually they get back into the plasma, where they will bind to albumin again and get transported around the body. All right. So, but however, uh, more conjugated bilirubin may accumulate in serum when the hepatic excretion of the conjugated bilirubin is impaired. All right. So, if there's an issue with excreting the bilirubin that normally in the normal state, that is even some unconjugated bilirubin, sorry, even some conjugated bilirubin will normally escape, as I said earlier, will escape back rather than moving into the bile duct. It might move back into the sinusoid and enter back into the circulation. All right, but when you have issues with excreting bile, such as when there is an obstruction of the bile duct for whatever reason, right? An obstruction means that the bile cannot flow, and so the bile will back up. And so when new conjugated bilirubin is formed, there is no the the bile ducts adjacent to the hepatocytes are already filled, right? And since the bile is not flowing due to an obstruction down the line, then the newly formed conjugated bilirubin will now pass back into the sinusoid. So this can increase the level of conjugated bilirubin within the serum. Hence, if you remember what we said earlier, that direct hyperbilirubinemia is when conjugated bilirubin within the blood is more than 15%. Is 15% or more of the elevated bilirubin. All right, so this is an example of what might lead to direct bilirubinemia when there is obstruction, biliary obstruction. All right, so this conjugated bilirubin too can bind to albumin, right? We started with the transport of bilirubin from the reticuloendothelial systems after the senescent red blood cells have been broken down, right? That was unconjugated bilirubin. So, but the conjugated bilirubin that might end up in the blood normally, or the excess that might end up when there is a biliary obstruction, this can also bind to albumin, and it's called delta bilirubin. Okay, and its own clearance, delta bilirubin's clearance from the serum, it takes longer than that of bilirubin. All right. So now, what does conjugation do? We said conjugation is the addition of glucuronic acid to the bilirubin molecule. All right. So this gives the bilirubin several properties. One is water solubility. Water solubility. This allows it to be transported in bile without a protein carrier. Without a protein carrier. All right. Now, it also increases the size of the molecule since two molecules of glucuronic acid has been added to it, and it decreases its affinity for albumin modestly, but it can still bind to albumin, and that's why we have delta bilirubin. Okay. Now, the conjugation prevents bilirubin from passively being reabsorbed by the intestinal mucosa. Now, because it is water soluble, we know that it is lipid soluble substances that more readily crosses biological membranes. All right. So once the bilirubin has been made water soluble, it will not readily cross cross biological membrane, so it will not be readily reabsorbed by the intestinal mucosa since it's now water soluble or hydrophilic. All right. So conjugation works to promote the elimination of of bilirubin, which is a potentially toxic waste product. All right. Now, uh, so so the bilirubin has been conjugated and has been passed into the bile in the bile duct, which has now been moved into the gallbladder. Okay, so but during meals, the bile is secreted into during the process of digestion. Bile is secreted into the small intestine. All right, and this conjugated bilirubin within the bile will not be reabsorbed from the proximal small intestine, as we have said, because it is water soluble and no longer lipid soluble, right? But if it was still unconjugated bilirubin is lipid soluble and it can readily cross membranes, and that is why transport or that's why the unconjugated bilirubin was transported bound to albumin. Okay, all right. So, but a little some of the unconjugated bilirubin to the that gets to bile, right? That gets to bile and eventually is secreted along with the bile, will be reabsorbed across the lipid membrane of the small intestinal epithelium, right? All right. So, and this will undergo enterohepatic circulation. What is enterohepatic circulation? This is just remember what the portal circulation is. That when the uh, when food is being digested, in the stomach, the large intestine, right? The nutrients that are absorbed from the food will be transported by a portal venous system from the gut to the liver. So it's the liver that processes these nutrients, detoxifies any toxins within the nutrients, and makes use of the nutrients, right? Processes them and sends stores some and sends some passes some into the blood for transport to tissues all over the body. All right. So so in this instance, this that's what the portal venous system does. It moves nutrient rich but oxygen poor blood from the gut to the liver. All right. So now, so when this happens, the your unconjugated bilirubin that escaped conjugation within the hepatocyte and ended up in the bile, they since it is still lipid soluble, it will be reabsorbed and go back to the liver via the this hepatic right this hepatic portal venous system, right, along with the nutrients that is being absorbed from the gut. Now this unconjugated bilirubin goes back to the liver and undergoes the whole process again, right? It passes through the hepatocytes. So some of it again will be conjugated. Most of it will be conjugated, but some of it might still not be, might still escape conjugation and end up again in the intestine again, and again they will be absorbed by the across the intestinal membrane, and this sets up this is what we now mean by the enterohepatic circulation. So it can be going sort of in a roundabout fashion. All right. Okay. So the not much additional metabolism of bilirubin happens within the proximal small intestine. However, in the distal ileum and in the colon, the conjugated bilirubin is hydrolyzed and deconjugated by uh, by enzymes beta glucuronidases within bacteria, to form urobilinoids. There are four main urobilinoids: urobilinogen, urobilin, stacobilinogen, and stacobilin. Okay. The nature and relative amounts of this urobilinoids depends on the particular composition of the bacterial flora in any individual's gut. All right. So now, urobilinogen is the major primary urobilinoid, and it is colorless. Urobilinogen is colorless. All right. So, but urobilin is orange yellow. Now, stacobilinogen too is also colorless, but stacobilin gives stool its yellowish brown color. Okay. So now, we've said that urobilinogen is the major primary urobilinoid, and 80 to 90% of this urobilinogen is excreted in feces, either unchanged or reduced to stacobilinogen, which is colorless. Now, the stacobilinogen is now oxidized to stacobilin, which gives feces its orange-brown color. Now, the remaining 10 to 20% of these urobilinogens is reabsorbed in the portal circulation, creating this enterohepatic circulation that I've talked about, all right, earlier. Now, if we were to go back to the schematic showing that we looked at the beginning, let's look at the urobilinogen again. Okay, so let's come back here. All right. So we said, this is inside the intestine, right? So we said the conjugated bilirubin is broken down within the large intestine, within the colon, the distal ileum and colon, to form urobilinoids, chief of which is urobilinogen. Now, most of the urobilinogen is excreted, is converted to stacobilin and stacobilinogen, right? And it's excreted in stool, but some of it will escape via the portal vein, through the enterohepatic circulation, and end up within hepatocytes, right? Within the liver cells, hepatocytes. Now, some of this and so this urobilinogen now escapes back into the sinusoids, right? Remember that it was the sinusoids that initially brought the unconjugated bilirubin to the hepatocyte. So some of the urobilinogen will cross the hepatocytes and move across the sinusoidal membrane of the hepatocytes into the blood, and from there it will eventually get to the kidney, right? And it's excreted in the kidney. It's eventually changed to urobilin, which gives urine its yellowish color. Okay. All right. So a small fraction will escape the liver, the hepatocytes, and filters, and eventually gets to the kidneys, as we saw in that schematic, and it's filtered across the renal glomerulus. But most of it will be reabsorbed by the proximal tubules, while this small fraction is excreted in urine. Urobilinogen is oxidated and converted to urobilin, which is orange yellow in color. So again, like we said, urobilinogen and stacobilinogen are both colorless, but it's the oxidized versions of them that have the yellowish or yellowish brown color, namely urobilin and stacobilin. Now, jaundice may be classified based on the types, either based on the site of pathology or based on the type of bilirubin. So based on the site of pathology, we may have prehepatic or hemolytic jaundice, hepatic jaundice, post-hepatic or obstructive or surgical jaundice. All right. So prehepatic just means that the problem is happening before the bilirubin gets to the liver. All right. Hepatic jaundice means the problem is within the liver, and post-hepatic means is after the liver. Now, it could also be classified based on the type of bilirubin, whether it's conjugated or unconjugated. I believe we now know what conjugated and unconjugated bilirubin means. Now, for prehepatic jaundice, now this is due to excess production of bilirubin, right? Due to excess breakdown of hemoglobin, and in this case, the hyperbilirubinemia will be indirect because most of it will be has not been will not be conjugated. So it will be indirect. It means that the direct fraction of it will be less than 15%. Okay. So causes of prehepatic jaundice. So there are so many hemolytic disorders from whichever type: inherited spherocytosis, erythrocytosis, and so on. Glucose phosphate dehydrogenase deficiency, pyruvate kinase deficiency. Um, okay, there should be deficiency in front of this: glucose phosphate dehydrogenase deficiency, pyruvate kinase deficiency, sickle cell anemia. It may be acquired, such as microangiopathic hemolytic anemias, paroxysmal nocturnal hematuria, spore cell anemia, immune hemolysis, parasite infections such as malaria. So anything that destroys red blood cells, right? Now, if that thing destroys red blood cells in excess of what um, the liver can handle, it will lead to prehepatic uh, jaundice, which is a indirect jaundice. Indirect because the since the problem is before the liver, then the excess bilirubin produced will not have been conjugated. Most of it will not have been conjugated. Now, it can also be caused by ineffective erythropoiesis, as in vitamin B12, folate deficiency, iron deficiency anemia, or thalassemias, or increased bilirubin production, such as patients are given massive blood transfusions, right? Or resorption of hematomas. Hematomas is just a collection, if you've ever seen somebody that was punched on the face and on the face or head, or hit with something on the head, and it swelled up really much, right? Almost as big as an egg, maybe swollen eyes, or that swelling is due to rupture of blood vessels within and that part of the skin, right? And the swelling is due to blood collection inside the tissue. All right. So when that blood is eventually absorbed back into uh, that hematoma, that is an hematoma. When it's eventually absorbed back, yes, it leads to increased bilirubin production. So there are some drugs too that could uh, cause prehepatic jaundice: rifampicin, uh, probenecid, and others. Now, hepatic jaundice. Now, the problem with hepatic jaundice is in the liver. All right. So if there is a problem of hepatocytes with resultant loss of the liver's ability to either conjugate or to excrete bilirubin. All right. So the causes could be viral hepatitis, alcoholic hepatitis, all right, drug toxicity, environmental toxins, Wilson's disease, autoimmune hepatitis, some inherited conditions such as Gilbert syndrome, in which the enzyme that is responsible for um, conjugation is deficient, UDPGT. When it's deficient, that is what we see in Gilbert syndrome. Crigler-Najjar syndrome, all right. When there's a problem, there's also a problem with the enzyme, to the UDPG enzyme. Then Dubin-Johnson syndrome, Rotor syndrome. Okay. Now, post-hepatic or obstructive jaundice, or also called surgical jaundice. All right. So in this particular case, the formation of bilirubin, the rate of formation of bilirubin is normal. Conjugation is normal. So meaning that the hyperbilirubinemia that results from this will be direct, as there will be more than 15% of conjugated bilirubin within the in this and serum, in plasma. All right. So any condition that will cause obstruction, of the of bile flow outside outside liver will cause this. All right. So viral hepatitis could also cause it. Conditions such as fibrosing cholestatic hepatitis, alcoholic hepatitis could also cause this. Some drugs could also cause this: primary biliary cirrhosis, primary sclerosing cholangitis. All right. Cholangitis will mean inflammation of the of bowel ducts. All right. So there are several of these. There's also cholestasis of pregnancy, benign postoperative cholestasis, and so on. Okay. So let's just skip all of this. We don't need to memorize all of this, but this is just a list of possible causes. Now, the other classification system is to classify uh, jaundice based on the type of bilirubin. All right. So conjugated hyperbilirubinemia, right? Any condition that will lead uh, to formation of direct bilirubin. All right. So some of the, of course, the conditions we listed under the other classification, yes, they will also fall into either conjugated or unconjugated hyperbilirubinemia. All right. So again, I will not dwell on this. So these are causes of conjugated hyperbilirubinemia. Now these are causes of unconjugated hyperbilirubinemia. Now let's talk about the epidemiology of bilirubinemia, uh, of jaundice. I mean, yes. Now newborns and elderly are most commonly present with disease. Uh, many as 20% of term babies have jaundice in the first week of life, primarily because their hepatic conjugation systems are not yet mature. Okay. Hepatitis A is the commonest cause of jaundice amongst children, but in the elderly, it's things like bile duct stones, drug-induced liver disease, and cancers, malignant biliary obstruction. Now, men have an increased prevalence of alcoholic and non-alcoholic cirrhosis, obviously because they drink more alcohol generally than women. Malignancy of the pancreas or sclerosing cholangitis. Women have more of gallbladder stones, gallbladder cancer, primary biliary cirrhosis. Okay, so bilirubin-induced neurologic dysfunction, so-called kernicterus, is a complication of severe jaundice that rarely causes death in neonates. Now, what's the pathophysiology of jaundice? All right, so basically, it's you can just we've already talked about it more or less even before now. You can divide it into the hepatic, right? That if there is prehepatic, if there is excess production of bilirubin, that will lead to jaundice, to hyperbilirubinemia. Or hepatic, if uh, anything that happens at the uptake, hepatocellular uptake, if there's a problem with the hepatocyte, right, meaning that the hepatocyte may not be able to take up the bilirubin for processing, or if there's a problem with conjugation. Some of those conditions like Krigler-Niger, right, when there is a deficiency of the UDPGT enzyme, right, or post-hepatic, basically, either there's a problem where the hepatocytes are not able to secrete, either from they're not able to secrete the bilirubin, the conjugated bilirubin, right? Either from obstruction or it could also be due to problems with the metabolism uh, of bilirubin, of the conjugated bilirubin within the intestines. All right. So dysfunction in the prehepatic phase will result in elevated unconjugated bilirubin, because since the bilirubin hasn't gotten to the liver yet, right? So it cannot be conjugated. So most of it will be unconjugated. But in the post-hepatic phase, the bilirubin has already passed through the conjugation systems of the liver, and so the hyperbilirubinemia will be conjugated or direct. Now, but the hepatic phase can cause both unconjugated and conjugated, because if there's a problem within the hepatocyte, yes, it might not, or at least until very very late stages, the problem probably will not affect all the hepatocyte, and so there will still be some conjugation of bilirubin going on. All right. So, but the pathologic hepatocytes might not be able to conjugate bilirubin. Okay, so now the mechanisms of hyperbilirubinemia, they could, for the unconjugated, it's simply could be due to um, either increased production or decreased hepatic uptake or decreased conjugation. Right. So if the production of bilirubin increases so much that the the liver is not able to take in that, there's no problem, there might not be a problem with the liver, but that because okay, due to say something like intravascular hemolysis, maybe a disease such as malaria or other disease that causes massive destruction of red blood cells, producing massive amounts of bilirubin. All right, and if the amount of the bilirubin produced is far more than what the liver can handle, all right, then it means most of the bilirubin will be unconjugated, right? Or if there's a problem with the liver and the hepatocytes are unable to take on the bilirubin produced, for conjugation, then again the hyperbilirubinemia will also be unconjugated. Or if there's a problem with conjugation, such as maybe deficiency of some of the enzymes involved that are involved in conjugating, especially UDPGT. If there's a deficiency in some of the inherited syndromes that we mentioned earlier, then this will also cause unconjugated hyperbilirubinemia. Now, for conjugated hyperbilirubinemia, now for this, what it means is that the um, the the bilirubin has already been it has passed through the hepatocytes and has been properly conjugated. All right, so it's usually caused by uh, caused by some hepatocellular dysfunction, right, or caused by cholestasis, stasis, basically stasis of bile, right? Because chole refers to bile. Stasis just means stasis, like a stagnancy. All right, so this cholestasis could be intrahepatic or extrahepatic. Intrahepatic in the sense that the hepatocytes have already they've already conjugated the bilirubin, but while still within the liver, the conjugated bilirubin cannot move further due to usually due to some obstruction. It cannot move it cannot leave the liver, or it could be extra hepatic cholestasis, such as obstruction of bile flow within the bile duct, right? So within the common bile duct, right? The bile ducts taking bile from the gallbladder to be secreted into the intestines. If that is obstructed by a gall stone, for instance, that will be an extrahepatic cholestasis, because the blockage, the stasis is not happening within the liver, it's happening within the gallbladder itself, and the gallbladder is not the liver. So that will be an example of extrahepatic cholestasis. Now, let's talk about the clinical presentation. Yes, of course, the yellowish discoloration of either skin, sclera, mucous membranes. The stool might be pale, pale clay colored, so like a kind of very light brown color. Uh, I would say the stool might be pale. The urine might be dark as a drink of soda, Coca-Cola. Urine might be that dark. There might be pruritus, serious itching. Those are some early features. Now we have xanthelasma and xanthomas when the deposition of bilirubin in the eyes. Then for malabsorption, there might be weight loss, steatorrhea. Steatorrhea is when the stool is excessively fatty, because the fat in the meals are not digested, and so passage of fatty stools. All right, osteomalacia, increased bleeding tendency, fever, rigor, pain, which are features of cholangitis. Okay, so this is what jaundice looks like. You can see the yellowish discoloration of the sclera. Now you can see yellowish discoloration of the skin here. in this adult and in this neonate. Now, the history, patients may be asymptomatic apart from jaundice, but they usually present with varying symptoms. Now, the symptoms will depend a lot on the particular cause, the particular etiology of the jaundice. Okay, so of course, for the clinician, we have to ask questions to try and find out the possible causes. So we ask about the use of drugs, alcohol, other toxic substances. You need to find out about possible hepatitis, HIV status, ask about anorexia, Malaysian hepatitis. Yes. Ask about the duration of jaundice, presence of any coexisting signs. Okay. Like I said earlier, fever, chills, and severe right upper quadrant pain seen in cholangitis. Now, weight loss might suggest malignancy. Significant weight loss might suggest malignancy. Uh, Severe generalized pruritus might point to obstruction, surgical jaundice. Okay, so a palpable lymph node, lymphadenopathy may point to malignancy. There might be ascites or hepatosplenomegaly uh, with patients with liver cirrhosis or malignancy. Okay. Now, carcinoma of the pancreas is an important cause of jaundice in patients over 40 years of age. Okay, um, gallstones are important in women, especially in middle age. A greenish cast to the jaundice indicates prolonged obstruction, which we'll see in the next slide. Right, so you can see for this lady, the eyes are yellowish, but the yellow has a greenish tinge. Yes, it might point to, it suggests an obstructive jaundice. Okay, so we might see scratch marks on the patient that will confirm the patient's history of pruritus. Then there are stigmata of chronic liver disease, spinal nevus, palmar erythema, gynecomastia, and so on. Okay, I think we can skip most of this. Yeah, the spleen might be enlarged due to the portal hypertension caused by hepatic venous obstruction, right? So hepatic venous obstruction that might lead to obstructive jaundice. Okay, will also affect the spleen, and the spleen might be larger than usual. Um, yes, the urine, as I said earlier, may be as dark as tea or as Coca-Cola. Okay, the stool um, maybe maybe brown, maybe light clay colored. Now, so these are some differences between the pre-hepatic, inter-hepatic, and post-hepatic jaundice. Okay, we'll not dwell on this. All right, so there are some terminologies that we should take note of. Charcot's triad is a triad of right upper quadrant pain, jaundice, and fever and or chills. This indicates acute cholangitis. Now, Raynaud's pentad adds two more things to this Charcot's triad, namely hypotension and altered mental status. Yeah, so this indicates more severe acute cholangitis. Now, Courvoisier's sign, that is when you palpate the right upper quadrant and you can actually palpate the gallbladder, right? So the gallbladder is enlarged but is not tender. Okay, it's due to obstructive jaundice due to tumors of the biliary tree or pancreatic head. So we also have Murphy's sign. We say Murphy's sign is positive if patient experiences right upper quadrant tenderness and stops breathing upon inspiration as the gallbladder moves down in contact with the examiner's hand. So this suggests acute cholecystitis. Now, other investigation. So it depends on the etiology. The investigations we can do. Of course, the first thing is to establish the amount of the level of the hyperbilirubinemia. All right. Okay. So we want to do the serum check for the serum bilirubin levels. Now, this is it's an overview of approach. So when there is hyperbilirubinemia, you will do liver function tests. If they are normal, in the sense that it's just the bilirubin that is elevated, but the other aspect of liver function test, the liver enzymes are normal. All right. So you want to find out whether it is unconjugated, if it is predominantly unconjugated or predominantly conjugated. All right. So if it is predominantly conjugated, then you are thinking of Dubin-Johnson or Otter syndrome, and you need to investigate further. You want to test for the enzymes, enzymes involved, right? If it is unconjugated, then you are thinking. Remember what we said about unconjugated bilirubin, that is predominantly caused by pre-hepatic causes. So it could be due to hemolysis, for instance, excessive hemolysis, or hemolysis of red blood cells, or Gilbert syndrome. So, but if the liver tests are abnormal, right, your AST, aspartate um, aminotransferase, alanine aminotransferase, and so on. So, there are several patterns. There are two patterns. It could be hepatocellular, meaning that there's a particular pattern of those enzymes that will suggest that the problem is within the hepatocytes. There's also a pattern that will suggest that the problem might be due to obstruction. All right. So, and then you investigate accordingly. Now, the liver function test. Yes, these are some of the things you want to do. So now for hepatocellular injury, alanine aminotransferase (ALT), aspartate aminotransferase will be markedly elevated. So, but for cholestasis, alkaline phosphatase, gamma glutamine transferase, and 5-nucleotidase will be elevated. Okay. Now for ALT, alanine aminotransferase, they are it's it's a cytoplasmic enzyme. Now AST has two isoenzymes. There is an isoenzyme that is principally cytoplasmic. That's ASTC, and there's a mitochondrial AST. Okay, all right. So they are so the ALT and the cytoplasmic isoenzyme of AST is they are elevated in injuries to the membrane of the hepatocyte, such as that caused by viral or chemical hepatitis. Okay, so but elevation of mitochondrial AST um, is caused with mitochondrial injuries, such as in alcoholic hepatitis. Now, alkaline phosphatase and gamma glutamyl transferase, they are found on the canalicular surface of the hepatocyte. All right, and so their elevations suggests obstruction to the flow of bile. Right, they are found in the canalicular. Remember where there are we refer to two surfaces of the hepatocyte, the canalicular and the sinusoidal. All right, so elevation of these two suggests cholestasis. Okay, so you want there are some final points of our liver function test here, which there is marked elevation of AST and ALT is typically seen in hepatocellular disease. All right, usually more than 500 international units, and there might be a mild increase of the alkaline phosphatase. So, but in cholestatic jaundice, as I said earlier, there is marked elevation of alkaline phosphatase and gamma glutamyl transferase and 5-nucleotidase. Okay. Now, let's talk. Okay. Concerning the serum aminotransferases, let's just talk about the ratio, the Ritis ratio. Okay, so ALT and AST are elevated in acute viral hepatitis even before the appearance of jaundice. Now, there's a ratio of the level of AST to ALT. Now, normally in liver cells in hepatocytes, the proportion of AST to ALT in hepatocytes is about 2.5 to 1. So there is more AST than ALT. All right. So one would normally expect that okay, this should mean that within the circulation there is always AST and ALT within the blood, within the plasma, right? So, but it's the elevation that we are looking for when we are trying to investigate investigate jaundice. But normally within the blood, their levels are about equal. Yet within the liver cells, AST is about 2.5 times more than ALT. And why is this? It's simply because the AST is removed from the serum by the liver's by the liver sinusoidal cells twice as quickly, right? The serum half life of AST is 18 hours, whereas the serum half life of ALT is 36 hours. So because of this, even though uh, AST is 2.5 times more than ALT in the liver cells, the ratio within the blood should normally be around 1 to 1. It should be around 1. All right. Okay. So if transaminase levels increase but ALP alkaline phosphatase levels are low, then the insult is hepatic in origin. Hepatic in origin. All right. Now we should note that AST, aspartate transaminase, is also present in several other tissues. Okay, so for instance, it can be increased. Can be increased after exercise, after intense exercise. All right. So we should we know that yes, this there are other tissues can release these transaminases. All right. Okay. So again, as we said, a alkaline phosphatase, gamma glutamine transferase, and 5-nucleotidase, they are located normally on the canalicular surfaces of hepatocyte, and so elevation of this will suggest cholestatic, obstructive jaundice. Okay, I've already said this. All right. Now, albumin is sensitive in the liver, and in liver disease. In acute liver disease, there's usually little change in albumin level. All right. So, but it is in chronic liver disease when it is low. All right. So, in acute jaundice, serum albumin is not likely to be changed. It's not likely to be abnormal. All right. Now, prothrombin time is also a test. We know that the blood clotting proteins, right? Most of them are produced in the liver. All right. So if there's an issue with the liver that might cause jaundice, the pathology might also affect production of blood clotting factors, and prothrombin time, right, might be prolonged. All right. So you could also look for biopigments within the urine. Okay. Now there's normally, right, there shouldn't be bilirubin within the urine. Right, what we normally have in urine is urobilinogen, which is supposed to be there, of course, but there's a certain level of urobilinogen we expect inside urine, but bilirubin itself should not be in the urine. So if you find bilirubin within the urine, definitely it's a conjugated hyperbilirubinemia, right? Conjugated hyperbilirubinemia, okay? So, which would suggest what? Either obstructive or hepatocellular jaundice. Okay. Now we should note something that bilirubin, when you collect urine that contains bilirubin, the bilirubin will be converted to biliverdin when the urine stands for a while, and biliverdin cannot be detected by the usual test for bilirubin. So when we are trying to test urine for bilirubin, it should be done on a fresh sample. Okay, let's keep this. Now, there are some radiological investigations. Plain radiographs, those are X-rays. Not usually, they are of limited use, as a lot of times gallstones might not be visualized because there are several types of gallstones. It's only several types of them are not radio opaque. They will not appear on the X-rays. All right. So ultrasound can be done. It's sensitive for looking at the biliary system, especially the gallbladder. Okay. Then cholangiography. Cholangiography is simply specific imaging of the biliary tree, and there are several techniques, which includes magnetic resonance cholangiopancreatography (MRCP). All right, so basically, it's using an MRI to He's taking an MRI image of the biliary tree. We also have endoscopic retrograde cholangiopancreatography. In this case, a endoscope, right, a tube, endoscopic tube that has a camera at the end is placed through the mouth and down into the stomach, and from there enters the duodenum, and the endoscope passes through the ampulla. Remember that the ampulla of Vata is where the gall, the bile duct coming from the gallbladder opens into the small intestine. All right, so that opening, the endoscope can be passed through it, through that ampulla of Vata, and it can visualize. You can look at the state of the bile duct, whether there are stones there or whether there is any other cause of obstruction within it. Then we also have percutaneous transhepatic cholangiography, when a a the hepatic intrahepatic biliary tree is punctured, right? So a needle is passed through the abdomen directly into the intrahepatic biliary tree, right? Under ultrasound guidance, then a contrast can be injected, and then a um, either a CT or an X-ray can now be taken. Okay, so you also have contrast enhanced CT of the abdomen. Then biopsy may be done, usually as a last resort. All right. Then we also have other blood works. Your viral serology to test for hepatitis, autoimmune antibodies, and so on. Now, what's the management of jaundice? It depends on correcting the underlying disorder when possible. All right. So if it's hepatitis that is causing it, you want to treat the hepatitis. If it's obstruction, then you want to treat it either with surgery or other non-surgical techniques. All right. So if it's a drug, of course you remove the drug. If you stop the drug, stop the toxin. If it's an infection, yes, antibiotics, antiviral, antifungal, and so on. Surgery to correct obstruction, use of chemotherapy, for malignancy, for cancers, dietary changes. People who drink alcohol, yes, they need to stop drinking alcohol, and so on. So the pruritus can be treated, yes, with warm baths, antihistamines, and or bile acid sequestrants, such as cholestyramine or cholestyramine. Right, the pruritus is due to usually when there is obstruction, and the bile. There's a biliary obstruction, so the bile salts will eventually get into the circulation and get deposited in tissues. All right, so the bile salts within the bowel, they're the ones that cause the itching. All right, so you can use bile acid sequestrants such as cholestyramine or cholestyramine and some other drugs. All right, if medical treatment fail, liver transplantation may be the only effective therapy for pruritus. For obstructive jaundice, there are some non-surgical techniques such as extracorporeal shockwave lithotripsy. In the case of gallstones, this is a technique that uses ultrasound to break up gallstones into smaller bits, right? Special type of ultrasound that breaks up the gallstones into smaller bits that will now be uh, passed into the bile and excreted along with the feces. Right. We also have endoscopic retrograde cholangiopancreatography. Now there will be surgical. Surgical management could be open cholecystectomy or laparoscopic cholecystectomy. Um, Other things, chronic hepatitis B and C infection. Yes, there are antivirals, interferon, liver cancer. You treat with chemotherapy, radiotherapy. For patients with end-stage liver failure, then liver transplant might be the only option. Now, whenever you see a patient that has yellowish discoloration of the skin, it might not be actually jaundice. There are some differential diagnoses such as carotenoderma, right? Yellowish color impacted to the skin of patients who have been consuming excessive amounts of some vegetables and fruits that contain carotene. Carotene is a pigment found in fruits such as carrots, right? So people that eat lots of carrots, it can lead to a yellowish discoloration of their skin. So the use of the drug quinacrine can also cause this yellowish discoloration and excessive exposure to phenols. Now, the prognosis of jaundice depends on the etiology, right? If it's jaundice from resorption of hematomas, uh, the prognosis is excellent because once the hematoma has been fully resorbed, then that will be an end to it. Or physiologic jaundice of the newborn, for instance. Yes, that's a good prognosis, and some other things, right? But things like cancer, malignant biliary obstructions, and they have a poor, or liver cirrhosis causing jaundice, the prognosis is poor. It's poorer because the underlying etiology, the prognosis for the underlying etiology is they are poor. Now, some complications. Now, the um, I said several times that bilirubin is a toxic substance, right? It's toxic to cells, and it is especially important in the neurological tissue, right? In neural tissue, you know, especially in neonates who have a poorly developed blood brain barrier. All right, this can cause permanent neurologic injury in neonates. There's something called connecteros or bilirubin-induced neurologic dysfunction. It can cause death in neonates. All right, so with that, we've come to the end of the lecture. Thank you for listening.